2021 as the Best Doctor Award. He has also received the Best Doctor Award in 2017 from the Government of Tamil Nadu. Now he is going to talk on critically ill children, the nutrition and the critically ill children. Over to Dr. Srinivasan.
Thank you, sir.
Forward, sir.
Forward.
Pointed.
Alpha is to be.
Pointed.
Okay, pointed there. Thank you for giving an opportunity. I thank Dr. Sendil and Puduvai team for giving this opportunity. This is not much discussed about the topic, how the nutrition is going to do some miracle in some children. Let me show you some case scenarios which has happened in ICH, how the nutrition is going to help in most of the recovery of the children. So first of all, let me go to the NICU, how the nutrition is going to play a major role. See, all you know, 2019 SRS data, we have 14.5 per thousand is the IMR and the NMR is 10 per thousand. If you take an NMR, less than 1.5 kg baby, around 30% of the babies are dying, and less than 1 kg baby, around 70% of the babies are dying. That means out of 6,000 deaths in Tamil Nadu, out of 1,10,000 admission in the SNCU, 6,000 babies are dying, out of it almost 1,000 to 2,000 babies are below 1.5 kg or 1 kg without any systemic illness. That means these are the babies where the nutrition plays an important role. So what is an important role? Why many SNCUs are not able to use the colostrum for all the sick newborn babies who are attended in the nursery? This colostrum is very important. Many studies have proven that this is going to prevent a lot of infection, a lot of chronic disease will be prevented for the children. So that means in the case of nursery, colostrum, how the colostrum is getting transferred to the mature milk, how to continue the mature milk, and how to continue the breast milk even after the discharge. These are the 4 critical interventions we should make. Why this colostrum is very important? God is really great that the colostrum, the superiority of the colostrum is directly, inversely proportional to the gestational age. What I mean by that the quality of the colostrum in a 28-week delivered mother is superior compared to the quality of the colostrum of a 37-week delivered mother. That means these young babies, 28 weeks to 32 weeks, has to be supported with the colostrum, and many neonatologists started doing smearing of colostrum over the lips of these babies so that this colostrum prevents most of the diseases like ROP, BPD, ventilator associated pneumonia, everything. And it has been beyond doubt proved that at the time of labor, the baby used to consume 600 to 700 ml of amniotic fluid, which contains lot of anti-infective properties. There's no other milk is comparable to this amniotic fluid, even not the breast milk, it is only the colostrum. Now the time has come that if you want to go for a single digit, the most important critical interventions every neonatologist, every nursery should make is give the colostrum for even in a ventilated baby, even in a HMD baby, whatever be the baby, colostrum has to be given. That should be the, I will say, L4 level of management in neonatal critical care. Next we will go to the PICU. Why PICU should be supported with nutrition? 40 to 45% of the outcome of the PICU cases are determined by the nutrition. You go see this picture. This is a very important picture. There is 2 phases called catabolic phase and metabolic phase. The catabolic phase occurs earlier when the child is really sick, when the child is in sepsis, when the child is in undergo surgery, whatever it is. This catabolic phase is followed by the metabolic phase. During the catabolic phase, lipolysis occurs, glycolysis occurs, protein breakdown occurs, everything occurs. If you don't feed the child during the catabolic phase, the metabolic phase will not get enhanced. It is proved beyond doubt in many adult studies, not in any children's studies it has been proved. So that means intervening during the catabolic phase, especially day 1 of PICU, the nutrition should be given a top priority so that the metabolic phase will get enlarged, so that the stay of the baby, the mortality of the baby, the morbidity of the baby will come down. So during the metabolic phase, you know, there is 2 phases called F phase and flow phase. During the F phase, everything will be silent, oxygen consumption will be low, cardiac activity will be low, everything will be low, enzymatic activity will be low. During the flow phase, enzymatic activity increases, consumption increases, cardiac contractility increases. That means there is a lot of need of calories and proteins for these children. The time has come for even in pediatric intensive care unit, if you don't start nutrition on day one of life, at least you should go by 50-50. 50% of the fluid should be given either through the orogastric or through the orojejunal feed, and another 50 maybe you can given in the form of IV fluids, where you should give importance to the 25% dextrose, which contains a lot of calories. Let me go to the, I think the slide you are running fast. Let me go to it's called, you can bring back, short bowel syndrome. You can go to the next slide. Next slide. So suppose I am not able to feed at oral, you should go for a TPN, starting protein from 0.5 gram to go up to 3.5 gram in the peripheral vein, lipid from 0.5 to 3 gram in the peripheral vein, 10% dextrose or whatever way you go up to 12.5% dextrose. Of course, you can give 3 milligrams of sodium, 2 milligrams of potassium, calcium and trace elements, all can be tried if I am not able to give OG or OJ feed because of the gut problem. Let me go to the next. This is an important case you would have seen in media in the last 2 months. This is called Isaki Amma, this yellow shirt baby. She was before consuming caustic and washing soda, she was absolutely all right. She is from Tirunelveli. After consuming, she had esophagitis, got admitted at Tirunelveli Medical College, got admitted for twice. Then the child went in for severe vomiting, could not take, the mother did not take much care, the child was left alone. Finally, the 12 kg child has become 6 kg when it comes to ICH. I shifted the child from Tirunelveli Medical College through 108 to ICH, thanks to the pediatric surgeon of ICH who did the gastrostomy on day 1 of life when the child received in it. Then after the gastrostomy, the child was initially 3 days was given TPN, then the child was given oral, through the gastrostomy feed, we improved the feed. I thank the Honorable Health Minister for giving accommodation in his MLA hospital for this baby for 4 months, and the baby was in the MLA hospital for 4 months, supported with lot of nutrition, of course with the nutritional department support. After 4-5 months, you can see the change. See how the child has become from a severe acute malnourished child, how the nutrition played a very important role. After 14 kg, the child has reached in just 5 months from 6 kg to 14 kg, then the child underwent the reconstruction surgery. Now the child is taking orally very well. Go to the next one. So I'll go to the another extreme. This is another child, again by the pediatric surgeon. We see in the ICH, compared to the physician, I think the surgeons are following lot of nutritional practices, especially when they do intestinal surgeries. They give first 1 or 2 days TPN. They start the enteral nutrition as early as possible, even when the child was sick. Even for a intestinal surgery, they start the enteral nutrition fast. This is a case of short bowel syndrome. What is short bowel syndrome? A syndrome where the intestine is less than 200 centimeter. Children can survive even with the 40 centimeter of intestine provided they have a good ileocecal junction, because this ileum is the most important part of the intestine. When the duodenum and stomach is not functioning well, the ileum can take over the function of the duodenum and jejunum. So this child has a short bowel syndrome, and the child had the short bowel because of the valvulus. There are other causes for short bowel syndrome. Go to the next slide. So what is the, go to the next slide. So what is the principle I followed in this short bowel syndrome? Lactose-free diet should be given. Complex sugar rather than the simple sugar. Protein should be given in the form of peptides, protein hydrolysates, or in a commercial protein X are available with 100 grams gives 25 grams of protein, and you can give instead of MCT oil, LCT should be given to this child for a good intestinal adaptation and the tropic effect, and child went on well. I'll go to the next case scenario. This is very interesting, the other spectrum of the malnutrition. Here is a child, is an obese child with hypothyroidism, came to my ward with this complaint. Cyanosis during the sleep for 1 day. The mother was not sleeping for 1 month, sitting by the side of the child, because the child, whenever the child flexes the neck, the child goes for cyanosis and goes for apnea. So the mother used to she used to be awake when the child is sleeping in the night for 1 month and brought to ICH. And this child underwent a lot of investigations. The child had excessive weight gain for the past 3 years. The child had adenoid and tonsil, and ENT surgeon opinion got. He said at present we need not remove the adenoid and tonsil, which is not that much big. That means the obstructive element has been ruled out. Then we did with the pulmonologist polysomnogram, where we found that the apnea-hypopnea index was more than 1.5. So then we did the echo showed severe pulmonary hypertension. So what to do with this child? So this child I took over in NRC, Nutrition Rehabilitation Center, Nutrition. We was trying only two options. One is the position of the child. The child should be always put on the right lateral or left lateral position, not on the supine position. If you read the textbook of pediatrics, they say keep a strong tennis ball under the back so that the child will not lie in the supine position. He will be on the right lateral, on the left lateral position. The child was given SPSM of diet. What is this PSM of diet? This is nothing but protein sparing modified fasting diet. It is like a military regimen. I advise only 800 kilocalories per day, irrespective of the weight of the child, for 3 months. Then you can go for maintenance phase, 1200 calories. After 1 month, the book says there will be a 10% reduction in the weight of the child. After PSM of diet in my ward, this child stayed for around 40 to 60 days. The weight from 32.5 has come to 29. For me, it's a surprise that the child did not need oxygen. The child was put on NRM. The child was absolutely normal. No evidence of sleep apnea syndrome, which the mother was encountering so many days. Most importantly, when I did the echo, mild pulmonary hypertension has come from severe to mild pulmonary hypertension. That means this protein-sparing modified diet, especially in obstructive sleep apnea syndrome, plays a wonderful role. I'll go to the next slide. So this is a case referred from the newborn baby, a case of A-beta lipoproteinemia, a proven case with a lot of acanthocytes. The child had the investigation, you can see the child had vomiting, oily stools and not gaining weight. LDL is 2, HDL is 3, 34, TGL is 9. Everything was very low. The child used to pass 8 to 10 times of stool with fat globules. So what to do? Go to the next slide. So we were surprised what to do. It was referred to the nutrition OP. And I myself and postgraduate thinking we should do for this some child. I don't want to discourage the breastfeeding in the child. So what I tried is, try to give only foremilk, don't give hind milk. I made the PG to observe the child for 5 to 7 days. See to that the child is taking breast milk only for 5 to 7 minutes. Don't give hind milk, let us see. Fortunately for me, after doing, of course the child was supported with the MCT oil and fat soluble vitamin A, D and K. You can see the length is increasing, the weight is increasing, head circumference is fine, abdominal distension has come down and stool has also come down, and this child went on home. Of course the future of the child is going to be the fat soluble vitamin with a low fat diet. I'll go to the next one. This is a child admitted last week with diabetic ketoacidosis. After undergoing stabilization, the child was brought to the ward for the nutrition advice. We followed what is called basal bolus regimen. The principles of treatment is Dane concept. What is this Dane concept? Dose adjusted against normal eating. Give the normal feed to the child. See the glycemic response and treat with the insulin. That is called Dane concept. Because always we are worried about the sugar, not the figure. So we are worried about the figure of this child. So this child was treated under Dane concept with the basal bolus regimen. The regimen is practiced like that. Go to the next slide. So this is the regimen. 2 idli, you weigh the idli in the digital scale. 200 ml milk, you weigh the milk in the digital scale. And you can take the carbohydrate count. All the cereals are going to have 15 and all the milk products are going to have 12. So this child had 30 plus 24, 54 carbohydrate count. The child was consuming 54 grams of carbohydrate. So 1/10 of this 54 is 5 or 6. This child was given with 6 units of rapid insulin and excellent control the child had. So time has come for the Dane concept for all these children should have a qualitative life in their qualitative diabetic life. Even though they are having a severe disease, but they can have a qualitative life with good increase in weight and height. Let me go to the next slide. Phenylketonuria. These are the children we come to our clinic. There is a breastfeeding policy for phenylketonuria. Go to the next slide. What is the breastfeeding policy? You have to measure the phenylalanine. If it is going to be above 2000, don't give breast milk for 3 days. 1200 to 2000, don't give for 2 days. 800 to 1200, don't give for 1 day. Below 800, give breastfeeding on demand fat. If I am not giving breastfeeding, what you should give? The child should be given PHFS, protein hydrolyzed food supplement, or LPFS. Of course, there are a lot of food has come now in the name of meta-nutrition PKU. That is where the phenylalanine will not be there, all the amino acids are there. So this child was supported with meta-nutrition PKU and they went on well. Once the child reaches 6 months, then you should decide this child should have 400 to 800 phenylalanine every day. You can depend upon all these products gives 50 milligram phenylalanine, milk 50 ml, potato 75 gram, rice 54 gram, wheat 25, cornflakes 15 gram. Go to the next slide. There are other IEMs where galactosemia. What to do with galactosemia? You cannot give breast milk. Child should be given soya milk. Some of the studies shows that there is a substance called stachyose in soya milk that can also comes into galactose can occur. So early weaning by 4 months is the norm for the galactosemia. We tried on a child, the child went on well. Go to the next slide. So these are the other, this is for the PG's purpose, MSUD, meta-nutrition MSUD plus thiamine should be given. Propionic acidemia, meta-nutrition PA plus carnitine can be given. Methylmalonic acidemia, meta-nutrition plus carnitine to hydroxycobalamin. Urea cycle disorder, sodium benzoate and sodium hydroxybutyrate. Of course, fatty acid disorders, avoid fasting and child can be supported with the carnitine. So the time has come that most of these children can have a good nutritional backup, that we can see galactosemia, phenylketonuria, tyrosinemia, MMA, these people also can celebrate the first birthday. Unfortunately, most of this IEM we are losing before 6 months, before we are not giving an 100% nutrition, because nutrition is going to be the only treatment for all these IEM. And you can have a severe acute malnourished child because of various illness. Suppose a child has a cardiac problem, your strategy should be 2/3 of fluid with adequate protein. If it is with the liver, we should strategy with the vegetable protein, with the good calories, with good fluid management. If it is going to be lung, you are treating with empyema or bronchiectasis or tuberculosis, where 2.5 to 3 grams of protein, you can increase your protein. In 1980s and 90s, many seniors are there. There is one thing called TB diet. It was given to the adult. After the TB diet, we have seen hundreds and hundreds of adult tuberculosis, the cavity, they become all right and went home. The time has come to concentrate on more nutrition for the respiratory pathology also. If you take renal pathology, is going to be a renal failure, protein is going to be very less. You can go 0.5 to 1 gram, don't go beyond that. Suppose you are dealing with a nephrotic syndrome, you are going to have high proteins, 2.5 to 3 grams protein, till the edema is there, till the protein area disappears. So there are strategies for all these illness, especially with the nutrition. Let us go like that. 50% you concentrate on drug, 50% I think you should concentrate on nutrition, so that many uncommon disease, many inborn error of metabolisms can come up. In fact, I have returned to the NRHM from the NRC of ICH that 25 lakhs I asked for the government of India to treat all this inborn error of metabolism, because now most of the inborn error of metabolism can have meta-nutrition with minus that amino acid, so that these children can be brought. In nutshell, if the children crosses the 6 months, whatever be the disease, they can celebrate the first birthday, the bright future will be there for the children. Thank you. I think I have finished in time. Thank you.
Thank you, Dr. Srinivasan, for finishing ahead of your time. And I think there is 1 minute left. We can have one question.
Any questions to Dr.
I have a question for you regarding this meta-nutrition.
Yes, sir.
Is it available?
Yes, sir. There is only one company, Pristine, is doing it in Bangalore, sir. In fact, I was about to visit the company to make an MOU with the government to get these products, because each 10 costs around 1,000 rupees. The people are finding it very difficult. The first 6 months, if you support with meta-nutrition, then our own rice products and other products we can try in these children, because most of these IEMs are dying before 6 months. It is available in India now, sir.
Thank you very much, Dr. Srinivasan.
Thank you. Thank you, Dr. Vijay Raghavan, Dr. Balashankar and Dr. Srinivasan for that wonderful session. We now request Dr. Vijay Raghavan, sir, to honor Dr. Balashankar and Dr. Srinivasan.
Can take the mic, I could not hear. Say generally the walking, running Sam doesn't need F75. No, I just come. Yeah, because generally even though the WHO says F75, to make an F75 I have to make an 100 ml. You put 30 ml of milk and you put 2.5 teaspoon of sugar to make the fluid as isoosmolar. So if you treating a child of 6 kg and you are going to give 8 feeds, you are crossing the fluid overload also. So in generally what I do in NRC, only 6 children are given F75. The other children who comes to the OP as SAM, we go by 1.5 gram per kg of protein for the expected weight. Because one problem with some child is not only preparation, fluid overload may be also there. Suppose a 6 kg child, if you give 8 feed, you may be giving 800 ml also. So that's why if you don't give, you restrict the fluid to 30 ml, 40 ml, you are giving an hyperosmolar fluid to the children. So only in 6 children we practice F75. In other children, mostly we don't practice F75, even though the program orientation for the public health people to practice F75 at the institution level, I think F75 for a sick child can be practiced. For an average child, for a normal child, need not be practiced.
Thank you, Dr.
Thank you. So I
Srinivasan.
think,
I have learnt a lot from both
yes,
of you.
yes.
Prostaglandin infusion causing cortical thickening of bones from Balashankar and meta-nutrition from Srinivasan.
Thank you,
Thank
sir.
you, ma'am.
May now request Dr. Vijayaraghavan sir to honor the speakers, Dr. Balashankar and Dr. Srinivasan.